I continue with the rest of the stories. Here in Nigeria, maternal mortality continues to be a big problem. Well, this is despite the fact that in a period spanning 15 years, between 2000 and 2015, records indicate that the number of deaths at childbirth reduced from 1,170 to 814 per 100,000 live births.
The northeastern parts of the country have the highest maternal mortality rate compared to other regions, with 1,549 deaths per 100,000 live births. This has been despite the renewed efforts of Nigeria's health authorities to arrest the scourge. However, contributions from the private sector have been substantial. Giving Birth in Nigeria is an initiative that focuses on establishing accountability for maternal deaths in the country. Their ultimate objective is to help create a world where no woman dies giving life. For more on what this initiative is about and what extent it has gone to secure the lives of mothers in Nigeria, we're now being joined by Dunni Olubode, who is the Nigerian Director, MSD for Mothers. Welcome. And Ofonagoro, Head of Project Epic Africa. Welcome.
Thank you.
Wonderful to have you join us.
Yeah, glad to have you join us. Well, let's start this way. Talking about the problem of maternal and child mortality in Nigeria, Yajiri, where are we at? Let's begin like that.
The problem of maternal mortality in Nigeria is well established. I believe the statistics show that about 1 in 7 women who die from maternal mortality around the world is Nigerian. Our statistics show that probably the size of the Abuja Stadium, which is about 58,000 women, die annually because of this problem across Nigeria. So it is a problem that requires urgent attention, and they're dying from preventable causes. So a lot of these deaths can be avoided, can be averted. So we need to pay attention to them and try and find ways to ensure that we're not slipping on this problem.
When you talk about preventable causes, 1 or 2 or 3?
Well, so the largest killer of women in Nigeria who die from childbirth is postpartum hemorrhage. Postpartum hemorrhage is, in many cases, avoidable by administering a uterotonic. That prevents the women from bleeding excessively. One of the challenges that we have found with uterotonics in Nigeria, there's a commonly used uterotonic called oxytocin, and it needs to be stored in a cold chain, for example, between 2 degrees and 8 degrees centigrade. And you know the challenges that we have with power in Nigeria. Studies have shown, a study published by the US Pharmacopoeia, that 74% of oxytocin available to women in Nigeria has deteriorated because it has not been
properly stored,
transported or kept in a cold chain. So those are some of the things that we're discovering and can be addressed.
Okay, I want us to look at some other issues before we come to what individually your organizations are doing to sort this problem out. We also have a problem with low levels of birth registration. I know that these deaths are recorded in some parts of the country, the northeastern part of the country. It's higher there than any other place. Now let's talk about the challenges that you have to face while talking to these people and dealing with the fact that illiteracy plays a part in these deaths as well.
So one important fact for our project is that it's going to be mostly centered in community. And the reason why is exactly what you've just said. A lot of people actually register and go and do their antenatal at the hospital, but at the point of birth, they prefer more rural, more traditional approaches, like the TBAs.
Is this a big problem? Because in other parts of the world, they sort of like also explore alternative means of having children. So why is it different with the local birth attendants here?
I think regulation. Okay. That's a very key part of it. Regulation, because in other parts of the country, yes, they have different. I think in South Africa they have a name for it. I forget the name at the moment, and they're legal, but those people still have they still pass through the normal skills training. So they have the optimum training of particularly finding out the signs. like watching the signs and avoiding the 3 delays.
Which are?
The 3 delays particularly follow the delay going to the delay going to the hospital at the point
when you're in labor.
When you're in labor, attendance while you're in the hospital, and figuring out what to do at that point. So for me, it's very tricky when you speak about traditional birth attendants here, because for places where there are no
health centers,
even when there are centers, there are no professionals in the centers to actually do the work. What do we do in that point? How do we address that situation? How do we deploy capacity to those places for them to work there? But when those people work and have no skills, do we leave the mothers in their hands still? Because a lot of women are dying in community.
The figures are unfortunately high.
No, the figure I was just saying before we even started the show, the figure that I particularly like to quote to make people be aware of this problem is the fact that there are 195 countries in the world, but Nigeria alone contributes to 19% of maternal mortality.
Yeah, so about number 4, worst place. Yeah. They say Nigeria is the most dangerous place in the world to give birth. Very troubling.
Yeah.
I still like to pursue what we're discussing earlier. Talked about the, you call it Europe, I can't remember what you call it.
Uterotonics.
Yeah, and you talked about the challenge that has to do with, storing it and all that. It's one thing to know about a problem. And I think it's to find a way to solve it, go around it. So what is your organization doing to be able to stem it, handle it? I mean, I don't know. How are you trying to handle that aspect?
Okay, for that particular challenge, one of the things that MSD for Mothers has done is we entered into a unique collaboration with the World Health Organization and a pharmaceutical company called Ferring, who have manufactured a heat-stable uterotonic called carbetocin. Now, what we've done with WHO is to have tests done in 30 countries around the world, Nigeria inclusive. Tests were done in Ondo and Oyo, including some Nigerian women, to establish that heat-stable uterotonic, heat-stable carbetocin can be used and is not inferior to oxytocin for the prevention of postpartum hemorrhage. So that's one of the things that we're doing. The project, the Giving Birth in Nigeria project, is another one with the support of our partners.
What's it about, Giving Birth in Nigeria? What's the initiative about?
So for Giving Birth in Nigeria, what we want to do, one thing you said before we started as well was it's a big problem, and how can we actually fix it or attempt to bring down the numbers. So a lot of projects have been doing great work around Nigeria. Like, it's really good to see that the data has gone down. It's because the only way you can know that is actually if you go and find the data. And one thing we believe because I speak for...
So there is improvement.
So there is improvement, but it's
not
still...
at the level you'd have wanted it to be.
Not at the level.
Better. Yeah,
but then one very strong point we will want to push out for this project is accountability. Because accountability goes further to speaking to the problem and speaking to people looking towards finding solutions to the problem.
Accountability on whose side?
So
the people who...
All sides. So this is the best part. I give you an example. Yesterday we had the launch. We had it in Ekpe, which is hopefully one of the local governments we're going to be working in Lagos. And just there in the room, we had the Bale, we had the chief imam, we had the head of the Okada Society, we had the Apex CNO. So we had
influential leaders.
Yeah, very, very, very influential key stakeholders. And tell you one beautiful solution that came up just right there sitting down. So the Okada rider, apparently now in Ekpe, Okada riders cannot work past 10 p.m. Okay. So we're sitting there and the Okada rider stands up and says, we will be penalized. We will be violating a rule if we help a pregnant woman to go to the hospital in the middle of the night. And what happens when on our way back to our homes after doing such a job? Immediately right there, just because of that engagement, the deputy chairman stood up and says that this is a problem that they've been thinking about for the longest time. That yes, you will not be penalized if this thing happens. Immediately right there, the Apex North said that what we can put in place is we could write a note for Okada riders that help the pregnant women here and give to them so that if they meet a policeman on the road, they present, we have just helped this woman to the hospital, I'm just trying to get home. You know what I mean?
Yeah.
For us, solutions like that, they are the key to the success of this problem. I said to them right there that we said to them right there that you don't know how many lives you have just saved with that simple...
With the right policies.
Yeah.
Very simple, very ordinary,
ordinary,
you know.
but magical.
You know, let me look at the SDG 3.1, which is to reduce global maternity ratio. Do we have a projection of how much impact you can make with these initiatives that you've started, what the numbers will look like, or how you intend to, or how well you intend to perform to bring down these numbers, let's say by the end of the year, and how close are we to meeting these SDG goals if we go at your pace?
So numbers are very dicey to quote with the approach that we're using. We want to start conversations. We want to catalyze these conversations. And like we've seen yesterday, the solutions like this will come and would build on and go on to do greater things. I can already speak for our organization, EPIAFRIC. We're thinking about working here and thinking about working with MSD for Mothers on this project. We organize hackathons every year. They're solutions building platforms, but we have a health and tech one. We centered this particular year, this year's one, on maternal health. We didn't center it on maternal death, but maternal health. But we listed all the different bits, all the different themes that, and the areas that people can, from emergency to maternal, even like helping to bring down maternal mortality. This is the kind of conversations that we want to spark in all little key stakeholders, policymakers, other organizations, to this is what is happening. These are the numbers. These are the true numbers, because we're not just quoting what's happening at the facility level. We're now going to go into community and get data from community to show the true face of what not going to the facility can do.
Okay, let me ask this, Dunni. You can't apparently do this without the input of government.
Exactly.
Both at the federal, at the state, at the local government. She talked about communities. So how do you expect them to pitch in such a way that you can get the kind of success that you're looking to get?
So I must say that the government has been very supportive. The current minister is an OBGYN person himself and has lent a lot of support to the cause of maternal health. We're trying to create a new norm, and this is what this project is about. We're trying to create a new norm around, it's not normal, it's not usual to have women dying. People need to start seeing it as abnormal, and people need to take responsibility. This project is giving the community, is giving women a platform to understand, to articulate what the challenges are. Why are women dying? That is a big question that this project is going to answer at a community level. Get people in the community to share their experiences.
Yes, because I was going to ask you, while you're still on that, how you're creating awareness of the people that matter, which of course are women. You know?
Exactly.
Because the voices of the women, the voices of the community go into fashioning a solution that works. Many times we're creating a solution to a problem that we haven't fully understood.
Context.
This project is going to give the community a voice. It's going to give the women a voice to articulate what the challenges are. And it's going to make everybody accountable. So not just the government, the community, the facilities, everybody is being held accountable.
Even the woman
every life.
Yes.
who takes in and gives birth.
Yes, because for too long, people have settled for, she died, it's normal.
It's a normal thing.
Everybody knows at least one person in their family, their friend, who has died giving birth. We don't realize how abnormal this is until you speak to people in other countries where they've made progress with maternal health. So our vision is to get everybody around this accountable, aware, and, contributing to that voice and hearing and understanding so we can reach a good solution.
Just speaking to actually the approach of the project. So I'm speaking for the consortium. Because it's not just EpiAfrique, it's not just Nigerian Health, it's not Africa. We're going to be working together because of the key strengths that we each bring in. So Africa is the oldest international African NGO known, and they have one of the biggest tools is their local connect in communities. In most states in Nigeria, they have linked most communities. So they're the ones who are going to be working at community level and just doing what you said, helping those women understand the problem, speaking to the people at the community level and giving them that sense of, okay, these are the things that you ought to know. For EpiAfrique, we are going to be mining and building the data, working with, trying to build a MPDSR system that will work at collecting maternal death data.
Okay. We get that part, the data part.
The data. So the MPDSR system is literally the system that the national level and state level that's used to collect data at facility level for maternal death. This is the norm. Data is being collected. So it's not like there's no data being collected for maternal death. It happens that after every death, there is the summary taking there's the survey and the taking for every death at facility level. So now at community level, cause of death, everything is recorded. At community level, most times you don't even get to know. Some cultures just bury immediately. Yeah. Some cultures is just like not even. It's not a spoken. It's like a.
Don't talk about it.
It's a hush topic.
It's anathema.
Yeah, exactly.
How far and wide have you been able to go? I mean, we have 36 states in Nigeria. This is Lagos.
Yeah.
How far have you been able to spread this news? And how farther can you go? And what's been your greatest, or what is your greatest challenge in being able to spread it, make sure it goes wide to the communities, not just the states?
So we're working in 6 states and the FCT. So we're not just working in Lagos. So we're working, and we've chosen 1 state per geopolitical zone. We've chosen Kebbi State, Bauchi, Niger State for the Middle Belt, Ebonyi for the Southeast, Bayelsa for the South-South, and for the Southwest, we've chosen Lagos. So, due to resources, we can't go to each and every state, and even in each state we go to, we can't go to each and every local government and each and every community. But then that's where the amplification that one of the consortium, Nigerian Health Watch, comes in. They're a social media platform that amplifies the work that we do on social media through our stakeholder meetings, such as the one we had yesterday, to not just tell Nigeria, but to tell the world that this communication is going on, this is happening, and this is something that can also be replicated in different places.
Right, now before we go, I think that there's an important point I'd like to touch on. Personally, I think that is important. Now, nobody talks about the snowball effect of having so many maternal deaths, having them high in the country. So you talk about the problem, but if it's ignored, it will lead to something else. Now, one thing I know for sure is that a child whose mother dies at childbirth is 3 to 10 times more likely to die before his or her second birthday. So what is the effect of a high maternal mortality on a society?
Thank you. This is a fantastic segue into what MSD for Mothers calls the mom effect. Now, MSD for Mothers is focused on maternal health. Our vision is to create a world where no woman dies giving life. And this is because a woman is very central. She's central in the family, she's central to the community. If a woman dies, the likelihood that her children will be well-nourished, will go to school, will get a good education and make something of their lives is diminished. If a woman dies, it means that the cycle of poverty is perpetuated not only in that family, but also wealth in the community, wealth in the nation. So it goes beyond just that woman dying. And this is what we're trying to get a lot of people to see. I'm really glad that you raised it, that the death of a woman, the death of a mother, you know, has significant impact and significant consequences, not just on the family, not just on the community, not just on the society, but even the productivity of the country.
And it's good that you raised that, because one aspect, usually when we go to get data, we'll just go and get data as scientists. But for this, we have recognized that we would need the help of a clinical psychologist to kind of help us dissect what this has meant to this family, that this woman has died. And that is also going to be one part that's going to feed into our Why Are Women Dying report, which is the final output for this project, which will now be publicized and used, and hopefully used to spur on more solutions that will be highlighted from problems that will be highlighted in the report.
Thank you so much
for
your good work and your contribution on Arise Africa, rather. You're watching.
Idea.
Yeah, it is.
The best.
You're watching Arise News. We'll be back shortly with more stories on Arise Africa. Stay with us.